Okay, thanks very much. I'd like to begin by acknowledging the traditional owners on whose land we meet today and paying my respects to their elders past and present, and to recognise the significant and important contribution that Aboriginal and Torres Strait Islander people play in relation to the Department of Health's programs. And I'd also like to say that one of the great things about working in government is that we work as a team, and I want to acknowledge some of my colleagues who are also involved in this. Samantha Palmer, who's here, who's responsible for Indigenous programs and also rural programs in the department, Alice Creelman, who runs the cancer branch, and in particular I'm here to deliver a presentation that has been provided by Dr. Tracy Bessel, who's responsible for breast screen and cervical cancer screening programs in the department. And I want to acknowledge Kate Jorgensen and Dr. Bernie Towler, who've done enormous work in terms of the bowel cancer screening programs, and Philippa Lowry, who's the director of the cancer group that I work most closely with. And it's a privilege to work with such an important contributory team. So I want to start by saying that I've given a lot of talks in my time on cancer, and I think that Sandra's is one of the best I've heard on prevention and the sort of epidemiology of cancer and what causes it and the risks. And I guess that the holy grail in cancer is about preventing cancer, and that's what we all try to do. But what I'm going to talk about is basically what happens when we haven't been able to prevent it, but we want to catch it early, and that's what screening's about, and I'm going to talk about that today. You've heard from Gail and also Helen and Sandra about the burden of disease in cancer. I'm not going to go through that again, except to say I think it's important from the Department of Health's perspectives to remind everybody that this is a significant impact on healthcare resources, and every dollar and every consult that we spend on diagnosing and treating cancer is one that we don't have to spend if we can actually prevent it and catch it early up. So it's not just a question of quality of life, it's not just a question of survival, which are the most important things. It's also about the most efficient and effective use of our healthcare resources. What we do in the Australian government is to provide a number of risk prevention factor programs in terms of focusing on obesity, alcohol, smoking, as Sandra's talked about, and it's really important that we recognise the multiplicity effect of that, I think, particularly for Aboriginal people. And I'm going to talk now about the 3 national population screening programs, which are bowel, breast and cervical. And I want to talk to you about the fact that a screening program is basically for well people, for asymptomatic. So we're not talking about detection when you suspect that something's wrong and go to your GP or doctor to work it out. We're talking about how can we early up screen the whole population, screen the people who we know are most at risk within the population, detect it early. And I think one of the really nice things about Sandra's presentation was showing you in many cases cancer can be fairly rapidly developing, but in most cancers it's really quite a long trajectory, and what we're looking for is the early signs of cancer developing so that we can interrupt that flow early up. We can screen, we can detect, diagnose and proceed with any treatment as appropriate. So that's what a population screening program is trying to do. It's got some important features, I think, here, and that is that we must be able to detect it pre-disease. So there's a lot of other cancers that we love to be able to detect early on, something like pancreatic, for example, but we don't know what the early signs are. So we've still got a lot of research and a lot of work to do. But where we have the population screening programs, then that's where we can make a difference. Importantly, for a screening program to be effective, the benefit must outweigh the harms. Every time you give a screening test to somebody, every time you suggest to them, even when they walk into the clinic, that they might have cancer, there are some psychosocial issues about that. There are issues about getting it wrong. There are issues about making sure that the benefit outweighs the harms. Very important in terms of the overdiagnosis issues, and very important in terms of recognising that what we do is we need to get it right. And no test is perfect, so we're not going to get it right all the time, but we're trying to get it right for most of the people most of the time. An organised systematic approach, and the WHO, the World Health Organisation, has put forward some principles for screening, which is that you must have an opportunity to recruit people to be able to, there's a suitable screening test. That's pretty hard for us. We struggle with that, for example, in relation to prostate cancer. We're still working that through in relation to lung cancer. And we must have the opportunity to do assessment and follow-up and appropriate diagnosis with the outcomes. What's happened here? So, what are the national screening programs that we have that are provided and supported by the Australian Government? Very importantly, in association with and supported by all the states and territories. We live in a federation, and the screening programs are very much done in this context, particularly Breast Screen Australia, where we have, since 1991, as Helen told you about, we've had a breast screen program, and until recently, we've had it that it's only been basically from 50 to 69. But the government in the last budget announced $55.7 million to extend the screening age to 74. And I guess as Helen showed you in her slides and talked about it, you know, we're all living longer, we're living older. Essentially, cancer is primarily a disease of older people, so we need to pay more attention to this as people get older, and we also know that there's more opportunities to do well, so we can certainly continue to save lives as people get older. So 2-yearly mammography. Mammography is still the best way to detect breast cancer early, and we have provided through the Australian Government together with sports and states and territories 2-yearly free mammography. Bowel cancer screening was introduced initially in 2006. From my point of view, in some ways, it's the only truly preventable cancer in terms of being able to get it very early because of the fact that we can remove the polyps. 95.9 million was provided by the Australian Government in this budget to extend it to 2-yearly FOBT testing, which is the particular test we use in Australia called the fecal occult blood test. And by 2020, we should be up to full screening. Cervical screening is actually an amazing success story in Australia. We've done better than any other country who've got the data to show that in terms of how we've done. We've had a 50% reduction since the introduction of cervical screening. 18 to 69-year-olds we have currently are eligible to have a 2-yearly Pap test. We are now looking towards introducing HPV testing, and I'll tell you some more about that. And in particular, what we think is that by 2016, we've still got a lot of work to do to put this program in place, but we'll be moving to a 5-yearly primary HPV test. And these are all joint, as I've said, these are all joint programs between the states and territories and Commonwealth. Okay, I'm just going to go very quickly over this. One of the difficulties that we continue to face, and I think everybody who's committed to Aboriginal and Torres Strait Islander improved health outcomes has struggled with trying to get better data to say we need to understand, we need to be able to encourage and support our Aboriginal and Torres Strait Islander people to self-identify so that we can get a better handle on how we can help you and what the differences are. We've got some differences in terms of the screening in breast, bowel and cervical, but with something like bowel we can't tell. We don't have the data to say what percentage of Indigenous people are being screened because it goes through Medicare. We correlate it with the census. That's not exactly accurate. And we've got a problem with cervical screening where we don't get Indigenous status on the path forms. So we dearly love to be able to have better data in order to be able to make a stronger case for improving your health outcomes for your people, but we continue to have a bit of a struggle in relation to identification and collection of the data. But we, through the Aboriginal and Torres Strait Islander programs that we're initiating in government, we're working very hard to improve our understanding and knowledge and recording of Indigenous status on all health records, and particularly when we move into the age of the personally controlled electronic health record, we're hopeful that that will really help us in terms of understanding more as well. Okay, so just in terms of the 3 programs, this is my favourite slide actually, the one that's of the truck being hauled over to the Torres Strait. And the programs there, we've got 32 services. I think one of the strengths of the breast screen program has been that it's actually taken the services to the people where they live. That's been really important. And we've got a number of different ways of providing those services. The current initiatives, we're expanding it to 74, as I've said. Something that's really important is we had a review of breast screen evaluation, and that review was chaired by Professor Helen Zorbas, and we are now starting to do an accreditation review. We're very close to streamlining the accreditation. It's very important that when we have screening programs that they are, provide safe, effective, appropriate care, and that it doesn't matter where you live in Australia or which service you go to, that you get the same quality. So we're looking to try and improve our screen reading. And this is not about the fact that we don't do well. We do very well in all of our screening programs, except we want to do better. We have a systems improvement approach. So we've got a reader assessment strategy through Sydney Uni where we're trying to improve the radiology results that we get. Really importantly is about consumer information. There's a really good pamphlet on Breast Screen and You, which is about the benefits and risks. I'd encourage you to have a look at it on the Breast Screen website if you want to know more about that. And also, more recently, we're very proud to say that NT has got a local four-wheel drive van that sort of crosses all the creeks and so on, is taking breast screen services to more women in the NT. Bowel cancer screening. We're currently inviting 50, 55, 60 and 65, and the invitation is by direct mail. And if you like, it tends to mimic much more the cervical cancer screening. This time we decided that it was really important to make sure it was integrated to usual care and with GPs. It can be completed at home and posted in AusPost. And please, please, if you are in the age range, please just do it, send it back. This is a life-saving strategy. Early detection of bowel cancer really works and really saves lives. Encourage and support your family and your friends to do this if they're in the eligible range. The follow-up of positive results is through the GP and with follow-up to specialist care as appropriate. The current initiatives in bowel screening are that we're implementing 2-yearly screening. We've got a quality framework that they're working on. We're looking at some of the technologies and research. I mean, one of the things that I always say when I'm teaching people about cancer is this is the most rapidly changing science of all of the sciences that we know, including astrophysics and everything else. I mean, it's just mind-blowing how quickly the science is changing here. We need to keep up with emerging technology, but we need to make sure that before we implement and support new programs and new diagnostics that it's as good as or better than what we currently have. That's our gold standard. But we're looking at the emerging technologies. Importantly, we want to look at under-screened communities, and that includes Aboriginal and Torres Strait Islander people. We're looking, as I said, to try and do better program data capture, and it's always important to keep communicating with our audience. So within the bowel cancer screening program, we've got a 2-year project, which is a pilot project to plan and implement an Aboriginal Torres Strait Islander primary health care pilot, and it will be integrated with the existing primary health care chronic disease prevention mechanisms. And we're working through AMSs, and we're evaluating in particular the inclusion of bowel cancer screening information in the adult Indigenous health check. It's one of the ideas that people have got is saying, well, maybe we could do better with Aboriginal people if we packaged it in a better way. And I remember the very first time that I actually went up to the NT in the 1990s and an older Aboriginal woman said to me, you know, Rosemary, it's the same body. It doesn't matter whether you've got cervix or breast or bowel. When is it that government is going to start understanding that Aboriginal people need whole person strategies and screening? And I've never forgotten it, and I've always kept it in mind, and I think we're trying really hard to address that kind of issue. Okay, in cervical screening, as I say, we've been spectacularly successful in this country in terms of pap smear screening, and we've had a decrease of 50% in incidence. But as Helen has already told you, this is not the same for Indigenous people as non-Indigenous people. Something that I find a particularly compelling statistic is 80% of women who get cervical cancer are women who have either never been screened or have been screened a couple of times and then lapsed. Again, if there are women in the audience, your friends, your sisters, your mothers, your daughters, please encourage them to be screened. Again, cervical cancer is imminently preventable if caught early. Okay, this is a very busy slide. This is basically talking about the importance of the HPV virus in terms of cervical cancer. And I think there are 2 important statistics that I want you to be aware of here. One is that over 90% of all cervical cancer cases are caused by HPV virus. So we know we're onto the right thing. At the moment, however, the vaccination only picks up 70%. So and it's really because the vaccination is what's called HPV 16 and 18, and there are many, many different types of HPV. And what happens in terms of the natural history of a woman with HPV is a lot of young women, when they first start sexual activity, get HPV viruses, and a lot of the time it will spontaneously resolve. What we're trying to nail is where that doesn't happen. And in a third of the cases where you get to what's called CIN3, which is a sort of stage 3, aspect of cervical cancer, that's when they develop into the more invasive cervical cancers. So HPV vaccinations are very important. Again, please support and encourage your daughters and the people in the age range to have those vaccinations. You'll be saving lives by doing so. But also what's really important to recognise is that it's going to be a long time before we have a vaccinated population, so we've got to be very careful to continue to support people to have pap smears as well. Okay, so what you can see there, if you just see where the rings around it, that Tracy has presented in this presentation, and I should have said this is Tracy's slides, not mine. I've just taken them straight from her giving them to me yesterday afternoon, because unfortunately she wasn't able to be here today. The HPV detection is what we're now trying to nail in terms of cervical cancer. What we've previously been doing is we've been trying to do high-grade SIN, so we've been trying to look at cervical cancer directly through the pap smear. We've now got a sort of belts and braces approach, if you like. And I think I've dealt with all of that stuff there. Okay, this again is a very busy slide, but I just want you, so a lot of people have asked us what's the difference in the Plan New program. Just have a look at column 1, and that tells you what the current program is. Women aged 18 to 69 years getting 2 yearly pap smears as by the NHMRC guidelines. The committee that considers changes to any screening program, the Medical Services Advisory Committee, looked at 3 different scenarios, and basically they were looking at the conventional method, liquid-based cytology, which is another method of collecting the cells, if you like, and then HPV and DNA screening. And they looked at all of the different, this is just to show you that we've looked at really all the permutations and combinations in terms of interval, in terms of type of method by which we can do it, and what the guidelines are following the IARC guidelines, which are the ones in the triage options. And in the end, we looked at all of those different systems, and then what I'm going to hopefully show you is that the one that we've looked at with HPV screening, so we're actually now trying to move to a new system that says first let's test if you've got an HPV virus. If you do, then let's triage you in different ways, and I'll show you this slide in a second. But what we now know is that the new method that we're going to will have a 15% better outcome in terms of fewer cases of cervical cancer, fewer deaths from cervical cancer. So this is definitely a win for us and a win for you and your people. So the evidence-based recommendations were that a new cervical screening test should replace the pap test. We know about HPV tests as detecting them, and it's for every 5 years. That's what the evidence shows, the research evidence shows in terms of the vaccination of unvaccinated women. But one of the things you should really take away from this talk is that women can have symptoms at any age, and this is about population screening for asymptomatic women. If you have women who you know, friends and sisters and mothers and daughters and so on, who have any symptoms, get them to a doctor really fast, because it doesn't mean to say that symptoms can't develop at any age. This is about well women, and it's about screening. What we're also now looking at, really importantly, is possibly self-collection. So this is about the fact that we've listened to and understood that for many cultural groups and different populations, it can be embarrassing, it can be culturally difficult, it can be hard to go and go through and have a pap test, and we know about the issues for women who live in rural, remote locations, and also women of Aboriginal Torres Strait Islander background. So one of the things that we're trialling and having a look at is looking to see whether the under-screened and never-screened women, we might be able to support a program that's looking at self-collection. Now, basically what this is women being able to get their own sort of cell, in sort of the being facilitated by a nurse or medical practitioner to do a pap test themselves, to be able to collect the HPV cells and send them off to a diagnostic lab. Now, this is still being worked through, it's still being developed, but I think the important takeout here is we recognise that there are barriers in terms of screening. We're trying to look at ways that might be a bit more sort of culture-friendly, a bit more user-friendly in terms of what we can do. We're working with the AMSs, we're working with the GPs and nurses to see if there's some ways to overcome this. But it would have to be on or behalf of a medical practitioner who also offers mainstream cervical cancer screening. I'm not going to go through this. Tracy's got this, but this is really the algorithm of what happens if you're clear, what happens if you're not clear, and when you go through. What you probably can't read this, but down the bottom, I think probably the takeout of this slide is if there's any suspicion whatsoever that you might have cervical cancer, you'll be referred for colposcopy. And so we're keeping it as safe as we can, but we're trying to make the method less invasive. I've lost one. The next steps is more consulting. Okay, so the group is consulting with groups around the country, consulting with women, consulting with different groups to say what's important. There's a communications plan being developed in terms of the cervical cancer renewal program. We're also looking at the registry information, so how can we get better data? It's really important, and the implementation always takes longer than you think. So what are the change management? We've got to look at the MBS items. We've got to change. That sort of always takes a bit of time in government to get that stuff through. We've got to look at workforce in terms of what else we might need, and the practice incentive program, how that might need to be tweaked, and the communications and the guidelines. But that's a whole lot of things to say this is what we're actually working on. Okay, importantly, there's website, cancer screening, and the cervical renewal. If you've got any questions, if you've got any comments, then please feel free to log them there. And with appreciation to Tracy, and I'm sorry that you got me instead of Tracy. Thank you.